and welcome to another episode of Cardiometabolic Beat, brought to you by the Cardiometabolic Health Congress. Today, we have the pleasure of speaking with Dr. Jay Shubrook, a family physician and diabetes specialist, as well as professor and director of clinical research at Touro University, California. During this upcoming CMHC spring meeting, Dr. Shubrook will discuss the impact of COVID-19 on diabetes management, as well as a special symposium that will discuss the impact of COVID-19 on cardiometabolic risk. Thank you for being with us, Dr. Shubrook.
My pleasure. I'm glad to be here.
Based on what we know now, are diabetes patients at higher risk of getting infected with SARS-CoV-2, or is the risk more in developing severe COVID-19 disease?
Yeah, so I think I'd like to open to say that this is all brand new and information is becoming available each and every day. So with what we know today, it seems pretty clear that just having diabetes doesn't increase your risk of obtaining or getting infected with COVID-19, but it certainly is a significant risk factor for having a more severe course, higher morbidity, and higher mortality. But again, we continue to collect data and continue to explore this area.
How should patients with diabetes and COVID-19 be managed in the hospital setting?
Well, first of all, I think it's important for patients to make sure that they share with the providers that they have diabetes. Too often people aren't aware they have diabetes, and that's just the very first step. So when they're in the hospital, insulin is really the best way to go for diabetes. Most people with COVID have pretty severe hyperglycemia, and insulin is probably the safest and most effective and quickest way to get glucose under control. And we'll talk about some strategies, how to really optimize this in the hospital setting.
And part two of that question, is there an agent of choice, and does glycemic control matter?
Okay, well, the easy one is glycemic control certainly matters. There's plenty of evidence that hyperglycemia in people without diabetes provides worse outcomes, and hyperglycemia with diabetes provides worse outcomes. In terms of agent of choice, I think agent of choice goes back to that insulin, mostly because we know that people are very sick when they're in the hospital, and we know that insulin is the most mobile and titratable medication that we can use and has none of the contraindications that we'd be worried about, such as renal disease. And so absolutely, insulin is the treatment of choice.
Thank you. Is there any evidence that T2DM therapy should be modified in patients with or at risk for COVID-19 in the outpatient setting? For example, there has been a lot of speculation about the role of DPP4 inhibitors or discontinuation of SGLT2 inhibitors in this setting.
Yeah, and this is an evolving area. So what do we do with the treatment of patients with type 2 who, or in the outpatient setting, get COVID? And I think the one thing we could tell you, first of all, is talk to your patients and tell them, don't stop any treatment until they talk to you. And I think the first and most important thing is make sure your patients have a sick day plan. For my patients with type 1 or type 2, they know that when they get very sick, there's certain things they should do. So for example, my patients typically stop metformin and stop SGLT2s when they get very sick because I'm worried about dehydration and renal and/or metabolic acidosis. However, there are other medications that should be continued. And I think too often people just stop taking all their medicine when they're sick because they think they're not eating. And that's like the one wrong thing to do when you get sick with COVID-19. So make sure you have a plan with your patients on what to do if they get sick. And, patients get the flu, they get other things. This is not the only illness this will apply to. So I do think that you want to individualize a plan, have a sick day plan, and then let patients know which things should be stopped when they go to the hospital or when they get very sick.
Thank you, Dr. Shubrook. And final question, to what degree are we now seeing new onset diabetes because of COVID-19?
Yeah, so this is a really complex and evolving situation. We know that many people have come in without a history of diabetes and have severe hyperglycemia. Does that mean they have type 2 diabetes? In some cases, probably yes. Other cases, maybe they had what we think is severe stress hyperglycemia. But there appears to be a bidirectional relationship between diabetes and COVID-19. And we might even see an increase in type 2, an increase in type 1. And I think this is something that we really will discuss in our topic, but really we still have to get more data to fully understand because this is an evolving situation.
Thank you so much, Dr. Shubrook, for your time and expertise. And thanks to all of you for listening. We hope you join us at the upcoming CMHC Spring, which now has a complimentary registration. For details on how to register, please visit cardiometabolichealth.org. If you have any questions or if you have any feedback on topics you would like us to discuss on future episodes, we would love to hear from you. You can email us at info@cardiometabolichealth.org. Thank you so much, Dr. Shubrook.
It's been my pleasure.
Thank you, and until next time.